Good afternoon, everyone, and welcome to Medical Grand Rounds. Before we get started, I'd like to make a brief land acknowledgement. McGill University is on land which has served as a site of meeting and exchange amongst Indigenous peoples. We acknowledge and thank the diverse Indigenous peoples whose presence marks this territory on which peoples of the world now gather. I'll ask you to please enter your questions at the end of the presentation. Please enter them in the chat, and please remember to fill out a brief questionnaire that will be sent to you at the end of the presentation. This will let us know that you were here with us today. So our speaker today comes to us courtesy of the Division of Geriatrics. Our speaker is Dr. José Morais, who is known to most of you, I believe. Dr. Morais is a full professor of medicine at McGill University. He holds an MD degree from the University of Montreal and completed a specialty in internal medicine and geriatrics at McGill. He went on to complete 3-year research fellowship in nutrition and metabolism at the McGill Nutrition Centre. He's a senior scientist at the Research Institute at McGill University in the Metabolic Disorders and Complications Axis. In 2009, he became the director of the Division of Geriatric Medicine here at McGill, as well as at the MUHC and Jewish General Hospital. He is also lead of Dementia Education Program of the McGill Faculty of Medicine, and he was the founder and first director of the Center of Excellence on Aging and Chronic Disease in the RUIS McGill. He's also past president of the Canadian Geriatrics Society. His research interest relates to the assessment of protein metabolism and cellular regulation at the whole body and muscle levels, and of protein requirements with age, frailty, and diabetes. He's also participating in several studies involving the nutritional assessment of elderly persons with the aim of improving their nutritional status and level of physical function. He shares an interest in improving services and cares to patients afflicted with chronic diseases. He holds research chairs from the CIHR and collaborates in several projects supported by provincial and national agencies. He has more than 170 original publications, most of them in high-impact journal in the field of aging, nutrition, and metabolism. José, after all that, thank you so much for joining us today. For Medical Grand Rounds, the floor is yours.
Thank you very much, Nadia, for this kind introduction. There was no need to go in so much detail. Thank you all. And the reason why I choose this topic for a presentation is because November is the month for fall prevention as declared by WHO. So I have to make a disclosure here because I have received funds from the Montreal General Hospital Foundation to support the SAFE program that I will discuss later on with their respective donors to the foundation by Scotiabank, Grace Dart Foundation, and the Miral and Lina Sapuro Foundation as well. So the points we'll be tackling in this presentation will include the geriatric giants, the impact of falls, fear of falling, cause and risk factors for falls, clinical assessment, fall prevention at home, and the benefits of exercise and the SAFE program by itself. So you have received already information on the goals for the presentation, so I don't need to describe them. And I will start with geriatric giants. You know, many years ago in the 60s, Dr. Bernard Isaacs, a pioneer of geriatrics, have described a group of ailments that he called geriatric giants. There's 12 of them, and these ailments or conditions span all aspects of human beings, from physical to psychological and social aspects. And an interesting point here to emphasize is that though they may coexist and interact, they remain distinct conditions. And we tend, unfortunately, to mix all of them, and as a result, they are not adequately addressed. However, we have to remember that they can be improved and correctly treated for most of them. And what are these geriatric giants? Here is the list that comprises 12 of them. dementia, delirium, depression, incontinence, orthostic hypotension, elder abuse, osteoporosis, polypharmacy, physical pain, failure to thrive or malnutrition, frailty, and falls and dizziness. Today, I will focus on falls and prevention of these falls. When we approach so many conditions, we have a tool in geriatrics called the Comprehensive Geriatric Assessment. To do a proper geriatric comprehensive assessment, we need a multidisciplinary team that work in an integrated fashion to be able to respond to the need of older persons. Though it can be an assessment of some duration, like an hour, hour and a half, this can be summarized in 5 components used by the Canadian Geriatrics Society, what we call the 5 M's. And when we do our consults on ER wards and even outpatient clinics, we refer to these and we summarize the problems as mind for dementia, depression, etc., mobility issues, medication, multi-complexity, and what matter most to the patient to include their own objective. This is what geriatrics is about in our approach. Now, I would like to describe what falls and fear of falls really are, because by definition, we describe a fall as a sudden involuntary transfer of the body to the ground, obviously at a lower level, and this without syncope or fainting, because syncope mandates a different approach, which is that of eliminating arrhythmias, hypoglycemia, for example, or having seizures. Whereas in falls, usually the person remains alert, and we have to search for the causes of that fall independent from syncope. Now, something that is very prevalent in older persons is the fear of falling. And this fear of falling is defined as a persistent concern about falling, which may lead older persons to avoid activities that they are still able to perform. So there's a tremendous impact of fear of falling on their autonomy. Finally, I would like to attract your attention to the fact that physical inactivity and falls greatly contribute to the overall decreased health of seniors. An acute fear of falling keeps seniors rooted in place. This increases exponentially after the first fall, and we will have time to go over this aspect. In terms of prevalence of falls, the graph that is presented here clearly demonstrates 2 things. One is that as one progresses in age, the prevalence of falls do increase to reach about 30% of the population. And the results here are presented as rate of falls per 1,000 people. The second observation is that women in more pale box have more falls than men by about 50%. And the question is, why is that women have more falls than men? It has been proposed that women shows more gait variability, especially during dual task assignments. And this variability is a manifestation of a lesser good control of the gait. So retain that fall prevalence goes up with age, and more so in women than in men. What are the impact of falls? I already mentioned that 30% of seniors in the community above 75 do fall every year. And the interesting point here is that once a senior falls, there is a high probability in about 30% of the cases they're going to fall on the same year again. So there is some intrinsic factors or some environment factors that predisposes them to fall. And about 30 to 50% of seniors with hip fractures as a consequence of the fall will need to be transferred to a care facility. It's a tremendous impact on their lifestyle and quality of life. Thanks God, only 10% of falls lead to injuries, or injuries that needs to bring the person to the emergency room. But fractures in older people we fear so much the hip fracture because of already I mentioned the placement thing, but also because 20% of all the hip fractures are caused by falls. Now, next, an important point to consider as well is that 25% of all the senior visits to emergency room are due from falls. So if we can prevent falls, there will be an impact on emergency room visits by the senior population. It's not an easy thing, the fall management and the fall consequences that we should strive to prevent them. It's usually a long and painful recovery period, some of the time with very bad consequences, including death. We see after a fall a permanent decline in functional capacity if it's not addressed properly. And there's implications for increased mental health issues such as depression and anxiety as well. And once an older person is hospitalized with a fall, in general, their length of stay is 10 days longer than for other conditions. You know, in our present times of demographic shifts, you know, the falls imposes a tremendous impact, not only on the person, physical and psychological aspects, but also their caregivers and the healthcare system as a whole. You know that as proposed by or published by the Institut National de la Santé Publique du Québec a year ago, over the past decade, from 2011 to 2021, there has been more than 200,000 hospitalizations. Hospitalizations here being either visits to emergency room or really being admitted to the wards. And this is an average of more than 20,000 hospitalizations per year because of falls. And 70% or more of these falls are by people above 65. I already mentioned that it's responsible for 25 visits of 25% of emergency room visits by seniors, and it is the 6th leading cause of death among seniors. And again, retain that 30% of seniors who have sustained a hip fracture will need to be placed in a long-term care institution. So as a whole, falls have been estimated by the Public Health Agency of Canada to cost $2 billion direct healthcare costs in Canada. Amongst the different modalities to intervene and mitigate falls is exercise, which is 5 times more effective in falls prevention than other modalities. And in the present time of the aging of the population, there is a need to be more proactive and adopt preventive healthcare measures. And this with the aim of keeping our more vulnerable older persons at home and autonomous as much as possible. And obviously, to decrease the pressure on the healthcare system, preventive measures are needed, and I think preventing falls is something that we should put an emphasis on. So this thing of fear of falling is the perception by the older person that they should decrease their mobility, should reduce their moving around because they are afraid of falls. However, it's a false analysis of the situation, because the more they reduce their mobility, the more they are prone to have deconditioning, and this will lead to more fall. So we should be more attentive to this syndrome of fear of falling as part of our assessment, because about 30 to 50% of older persons do have fear of falling, independently from a previous fall. And once they fall, it just increases further this feeling of being unsteady and being afraid to mobilize because they think they're going to fall more. And this is more prevalent in women than in men. So we have to tackle that fear of falling. Here is a drawing describing this cycle in where loss of balance confidence leads to fear of falling, and they restrict their activity, which contributes to reduced muscle strength and impair balance further. The gait becomes even more unsteady, with a real increased risk of falls, and the falls do occur, and it enhances this feeling of becoming fear of falling. Studies have shown in a large study from NHATS in the States, where if you compare people with fear of falling as the green line, with those who already have experienced one fall in blue, with those who had multiple falls, you realize that being fear of falling in itself over time creates more mobility issues, as shown in the graph. And equally to those who already have fallen one or more per year, they have impact on their self-care activities that enables them to remain autonomously in their homes. So it's something to consider. So how to tackle falls? First, one needs to understand what are the risk factors associated. And there is so many risk factors. If I count all of them, divided in four categories: behavioral, environmental, biological, and socioeconomic, there is more than 25 of them. And it really takes a comprehensive assessment of these risk factors, evaluating each of them to come with a good understanding why the older person is falling. However, there is factors that have more weight than others. And in this meta-analysis of 16 studies that was published a few years ago in 2014, it's depicted the strength of each of the risk factors, and the most significant ones are the fact being above 80 years of age, showing some cognitive impairment, and this increases both of them by about 60% more. Being depressed also is conducive to falls. Obviously, visual deficits is a prominent risk factor, twice as more. The fact that someone requires to use a cane or a walker is also another marker factor for falls. Definite balance deficits, once assessed, or people having ataxia, is almost 3 times more as a risk factor. And finally, previous falls is a very strong risk factor for more falls, and muscle weakness as well, which is the champion. Increasing the weight is more than 4 to 5 times more than those who don't have muscle weakness. And I would like to attract your attention to the fact that exercise is a modifiable factor that can rebuild muscle weakness. So an ongoing exercise program is a viable solution to stimulate movement and strengthen muscle. So it's why exercise is so important in the management of falls. But before discussing management, what is the appropriate assessment of the falls? Ideally, we should have a multidisciplinary team, and this is why geriatrics works hand on hand with physiotherapists, with nurses, occupational therapists, etc. And it's important to take a good history, which includes warning signs of feeling dizzy or unsteady, but also the circumstances and frequency, because falls on a icy street is different from falling at home, where it seems that there is no risk factors, but there is environmental factors we need to deal with. Also the severity, because when is getting so weak and they have difficulty standing from the floor, regardless if there has been fractures or injuries, is a very significant severity risk factor. And obviously many chronic conditions that need to be taken into account. And then we need to proceed with a physical examination in which the vital signs, what orthostatic signs being measured, is extremely, extremely important. Our residents know that, and we insist for every case that comes to the attention of geriatrics that we have orthostatic values being assessed. A cognitive evaluation, already I've mentioned that cognitive issues increases the risk of falls, visual assessment, a complete neurological assessment to look at all aspects of the neurologic system, emphasizing on muscle proprioception balance in particular. Cardiovascular evaluation, reason for it is that we need a good cardiorespiratory system functioning well for endurance and performance. And obviously musculoskeletal assessment for looking for deformities, calluses and bunions in fungal nails, etc., as well as footwear of the person. We should always add an objective measurement of the gait by checking the way they walk. Those who come to my clinic, I never discharge a patient or after a visit without having previously walked with them. And at least one of these objective tests should be done, either gait speed, time up and go, sit and stand, chair test, and a balance that usually is performed by a physiotherapy when she's available or he is available, because the Berg scale that was developed at McGill in the 90s is used internationally to assess balance in older person. And in terms of endurance, if one can perform a 6-minute walk test or 400 meters test, it adds to the evaluation in terms of how performant and cardiovascularly speaking this person can tolerate exercise. As part of the evaluation, medication needs to be reviewed to avoid the polypharmacy and have an occasion to optimize medication. There is many studies looking at medications and which of them is more contributing to falls. And amongst a bunch of them, what is prominent here is the diuretics. And we know many people on diuretics, I mean, older people on diuretics end up having mild dehydration and or significant electrolyte disturbances that makes them more unstable. All of these sleeping pills, anxiolytics, they increase the risk and in a significant way, as stated here, by 42%. Any antipsychotic increase the risk 50% more, as well as antidepressants, anti-epileptic. Remind you that sometimes it's necessary to prescribe, but each time we see them, it should be reviewed for the dose. Is it still necessary, and not just prescribe it for life, as well as opioids that increases also the chances of falls by 60%. Once someone has 4 and more medications, this is the worst part of it, is that we call it, by definition here is polypharmacy. Some definitions include 5 or more medications, but it increases. The higher risk is when all of this is combined, 75% increased risk. So doing a proper medication review is something that pays off and should be conducted. Now, in terms of interventions, one has to treat what we find, and there is chronic diseases and acute conditions that can be better managed, and we should do that. Optimized medication already touched. Now, the last 3 points, I'm going to spend more time on it. One is adaptations that can be done in the houses, rehabilitation, and prevention and maintenance with physical activity exercise. Very briefly on rehabilitation, I am proud to present results we have conducted in geriatrics assessing the usefulness of our geriatric day program. And in many of the tests that you see here, Bartel, ORS, time up and go, gait speed, 6 minutes walk test, Berg balance score, hand grip, and quality of life, we have significant impact on these measurements. And I have done more just defining, is there a significant statistical improvement? I have also applied tests to assess the clinical meaningful improvement. And despite of a population whose average age is about 85 in our geriatric day hospital, I can say that for most of these items, around 50% of them have a clinical meaningful improvement and not just a statistical one. Now, we have to recall that about 50% of the falls happen at home. And we need to do interventions to decrease that home hazards contributing to falls. This is data from the PIAC agency in a report of 2014. And each of the most significant areas in the homes for falls are bathroom, and we can understand why, because of there is slip surfaces that should be addressed. We should when it's required, install bars to prevent falls when there is a loss of balance. And there is adjustments that can be made, and this is where occupation therapy therapist assessment can make a difference. Obviously, in the living room and bedroom, there is so many things sometimes that contributes to fall because of accumulation of items, but also things that we don't think, because we are, most of us, in good health and possession of our full physical capacity, but having cords and wires and rugs and all of this contributes to fall, and an expert OT evaluation can prevent this from happening, including at the kitchen as well, where sometimes we don't think of it, but there is improvement to can take place, to avoid older persons to need to take a stool to climb and reach for supplies, So if you have a patient who have falls, because not all the falls are seen by geriatrics, it pays off to have a home evaluation to prevent further falls. And in fact, a recent Cochrane review this year, including 22 studies and involving more than 8,000 patients living in the community, older persons living in the community, have found that that by modifying the house according to an evaluation of expert people, we can reduce falls in the home by 26%. And if we look after those who are considered to be a high risk falls, the impact on the reduction is 38%. Whereas if you select and you decided to modify the home in people who are not prone to falls, then you don't see any particular impact. If someone falls many times, then the impact is less, because there is other factors than the environment, than the home hazard that contributes to the fall, possibly some weakness or balance that should be addressed. But overall, it's worth doing home evaluation for safety issues, as demonstrated by this Cochrane review. I'm already showing you my my bias towards maintaining a good level of physical activity, because there is so many benefits, for older people. I don't even put a reference here so much, it's evident, but physical activity contributes to regulate appetite, promote healthy weight, reduce body fat, maintain muscle mass, improves cardiorespiratory function, reduces stress, and improves sleep. And in general, those who are most physically active, and physically active does not mean to go to a gym. because we can incorporate a lot of activity in our daily lives, with a regular walk that is accessible to most older people, and remain active in socialization and do our own autonomous activities, especially instrumental activities of daily living that requires one to go from home to groceries, take public transportation, go to bank, etc., etc. All of this is part of physical activity, implying that we should be less sedentary. And there's other things that we know from those who are physically active. They have fewer heart attacks and strokes, less diabetes, less obesity, less depression, anxiety, and things that we see a lot in older people, which is difficulty of falling asleep or sleeping adequately. Those who are more physically active also have less osteoporosis and fractures, fewer cancers, they live longer in general, and enjoy, above all, a better quality of life. So let's go for physical activity. What do we know about exercise and falls? A Cochrane review of 2019 with an incredible amount of studies, 108 randomized clinical trials, more than 23,000 people, etc. In general, any type of exercise improves the rate of falls by about 23%. And this is significant, meaning that comparing those who undertake exercise versus those who are not enrolled in programs of exercise, per 1,000 people a year, there is, in this comparison, of a decrease to about 200 falls less as compared to the control, with 850 falls. So it's a 23% decrease. This is what it means. The exercise has impact also on those who have had more than one fall, and especially in those who had fractures, the exercises decrease the rate of falls by 27%. And above all, the rate of consulting family physicians in their clinics because of falls, the impact is about 40% less. There is no significant decrease in terms of risk of going to the emergency room. The impact was just 22% and did not reach statistical significance. But overall, there is a very positive effect on exercise, on the rates of falls and the need for healthcare service. Now, this was the previous table for any kind of exercise. But if we do a multi-type, this is combining exercise specifically for balance, flexibility, endurance, strength, then the impact is even greater. So in a multi-type exercise, the reduction of falls is not 23, it's 34% as average. And those with one or more falls still very significant, 22%. So developing a program of exercise that is touched in multiple domains is the ones who have the most impact. And in fact, this is probably why Tai Chi also has a significant positive effect on falls by a reduction of 19%, because in Tai Chi, you work a lot on balance and flexibility, and sometimes on strength as well. Now, in terms of the effect of intervention of fear of falling, please do not read all this Forrester plot here, because there's so many studies and numbers are not readable. But I highlight that the standard mean difference of all the trials assessing fear of falling using measurement tools such as the fall efficacy scale shows a standard mean difference of 0.56. So a definite improvement of the fear of falling, that by now that it has impact on mobility as well as autonomy of older persons. So this is why, knowing all of these positive effects, the experience we have in our geriatric day hospital with rehabilitation of older persons with many falls amongst them and weaknesses, I created the Senior Adult Fitness Exercise website that we call SAFE. And the mission of this website is to promote healthy aging and improve their quality of life, maintain the autonomy of older persons, and allow them to continue to live at home. Reduce the risk of falling by up of 40%, as many trials have shown, and the Cochrane review showed that specific exercises, a combination of exercises, can reduce by 34% in average, and also as to decrease emergency room visits. And obviously, it will have an impact on our very busy and burdened healthcare system. So, what is SAFE? So it's a home-based exercise that is free. It's a series of exercise videos for seniors to help improve mobility and prevent falls. So the exercise program have 4 levels of difficulty in each of these 5 categories. There is a warm-up exercise. Then there is exercise addressing strength, balance, flexibility, and endurance. For each of them, there is 4 levels of difficulty. And I can say that it is easy to use, was made for that type of population. So there's no password to access, is user-friendly, easy to navigate, required no subscription. One can personalize the exercise by moving into the different categories and according with their needs and the easiness with which they perform the exercise, because they can be on a level of difficulty 2 in let's say in strength, and level of difficulty 3 for flexibility or balance. So it's turnkey ready. It's based on a lot of experience and research literature. It combats many negative aspects of sedentary lifestyle, and it can be done at home through a simple click of a button if you have access to internet and a computer. You know, always remember, retain that physical activity can reduce the impact of muscle loss associated with the aging process. Increase mobility, physical function, bone density, stability, range of motion, and balance. And it can have an impact on frailty prevention as well. There is a picture here of a patient of mine, and they consent to give their names and to be photographed. And this is how they use it. The caregiver daughter is working with the mother to imitate the exercise shown by a monitor, by a trainer. So why is SAFE a good choice for seniors? Make exercise accessible and easy to use for them using a home-based program. It's adaptable for the reasons I already told you about navigating different levels of difficulty and according to the category. It helps to prevent falls. And there is also some psychological benefit that is derived from the exercises themselves. And we hope eventually to diffuse these exercises through the CSPQ and RUIS of Quebec and maybe elsewhere as well. So the type of exercises, each of them have their own purposes. Like, sorry, there is a bilingual slide. So there is warm up, and it's to prepare the person to do more demanding exercise, loosens the articulations and the joints. Then strength for those who are specifically weak. This is tailored to that aspect, to give them the strength to walk with more safety. Balance, obviously, which is a major difficulty people who fall do have. So they are exercises to improve coordination and balance and give their sense of confidence that prevents fear of falling. So flexibility is so needed in our daily activities to enable one to reach out to to parts of the body that otherwise it becomes difficult for them to perform. And finally, endurance, so that one has the capacity to do more sustained activities. So is it just exercise on the SAFE program? No, there is more than just exercise, because we have recommendations for healthy aging. There is a section on frequently asked questions, useful resources, and obviously the exercise video as well. So it's for every person. The only need is to access the website. We are developing a booklet, but it's not ready yet. So far, what have been the success? I have to remind you that we launched this SAFE program about a year ago in November 2022. And by now, there's been more than 86,000 seniors following exercise, SAFE exercise program. So there is a Facebook community with more than 37,000 seniors and their caregivers providing feedback and showing their interest. And this is 65% more than we did estimated initially. So the conclusion is that this result not only points to a real need for this type of program, but also that SAFE's approach, tone, and content is generally resonating with people. And here is this is type of feedback one receives in social media about the program and about the usefulness and how they feel about it. But we have tried to have some more objective assessment. And once the program is out there, anyone can use it, right? So I was surprised to realize that a master's program student, François Lepage from Belgium, he did perform already some preliminary assessment. He just sent the data to me. So it was a 3-month exposure program where participants were invited to assess or to participate in 3 sessions per week of the SAFE exercises, and in 11 subjects, medium age of 85, average age of 85. Before and after results on the following tests: in Tinetti tests for mobility, Berg test for balance, time up and go for gait, chair standing 6 minutes walk test, and the fall efficacy scale, international scale. All of this shown to be significant. I don't have the values exact of the amount, but it was part of his thesis. I invited him to publish it as preliminary results. And right now, what we are trying to do is to have an assessment of the efficacy and adherence to SAFE. And for this, we have designed a randomized clinical trial of more than 100 frail, pre-fail older adults of both sexes. More than 75 years of age, and this is for 3 months duration as well. And in the intervention arm, they will receive education and training for a first week, followed by weekly phone calls to promote the engagement in the SAFE program at the rate of 3 times per week sessions. Whereas the controls, they will be encouraged to pursue their activities of daily living. After the 3 months, we will verify on the subsequent 3 months later in the intervention group by making a phone call with the questionnaire if they are still doing the exercises or not to verify adherence. And what we are measuring, functional tests such as time up and go, grip strength, SPPB, Berg, cognition as well, both with the MOCA, but as well as specific tests for cognition, assessing different domains, especially executive function, with things such as the auditory test, the Stroop, the digital test. So numbers of falls, because we're interested to see its impact. Fear of falling by using standard questionnaires and assessment, mood, sleep, diet intake with the 3-day food diary and activity level using accelerometers. We just received last week the ethics approval, so we're going to start pretty soon the recruitment, and I hope in the future to be able to show results. Voila, what I wanted to present to you, and we still have some minutes to discuss. These are pictures taken from the videos showing the type of exercises, and the different colors pertain to the level of intensity. So thank you for your attention.
Thank you so much, José. Thank you, Dr. Morais, for this fantastic, comprehensive presentation on a very important topic that I think affects all of us, whether we are, clinicians or with family members or for ourselves. So very important talk, and congratulations on the work that you've done. I'm happy to see all the uptake that you have. There's a few questions. Wendy Chu has made a comment on some education material on home environment safety. For those of you who are interested, you can click on this link. Nicola Toma has an interesting question here. Fantastic talk, but he wants to ask a question about mechanical falls. Can you elaborate on this ubiquitous term that is used, mechanical fall? It seems as one made to minimize the complexity of the sentinel event called a fall. Can you please tell us about that?
Yes, certainly. It's I would say a terminology that's used sometimes inappropriately. Is when the physician doing a superficial examination doesn't find the reason for the fall, then they call it mechanical fall. But there is always a reason. If it is not hazards of being on the street on an icy day or a home where there is a lot of clutter or rocks, etc., it's because there is some weaknesses. It's because there is a frailty with poor coordination, delayed the response time, so that when they are a little bit off balance, they never have enough time to recover their balance and prevent the fall. So a fall, I think, should never be taken as lightly. Many years ago, when I was a resident in the 80s, there was a commentary or a little article that I still remember. It was done by Dr. Mark Clarkfield, that at that time was chief of geriatrics at the Jewish General, who said, "Look behind when an old person falls." So in other terms, search for the cause, as opposed to say, no injury, go home, this is mechanical. They should be referred to community services to have more proper evaluation and perform assessments. So mechanical is a too easy terminology to apply. We should always look for causes and reverse as much as possible.
Thank you for that. George Hanasulis has a question that I'm sure is on the mind of all cardiologists who are listening to this lecture. As you know, in cardiology, a lot of our patients are anticoagulated for atrial fibrillation. The geriatric population is more at risk of strokes, and we are always faced with this question of, and the question that George poses here is, how many falls, what's your threshold where you feel it's not safe to anticoagulate a community dwelling elderly person?
Yeah, the benefit of anticoagulation is so great, to prevent cardiovascular and cerebrovascular disease, that you really have to be at I, and insist 3 times I, risk, to say stop anticoagulation. Because the overwhelm, the literature clearly states that the overwhelm benefit is such, overall is such that I'm not very inclined to stop any anticoagulation unless the balance is so poor that they really are at the risk of a major trauma. Okay, thanks God, only 10% of the falls leads to injury, soft tissue, or more serious when there is a fracture. So the evidences have to be very strong to stop anticoagulation. I hope this will reassure our colleagues in the cardiovascular system.
Thank you for that. Dr. Doss wants to know what amount of protein per kilogram is recommended by age group. Do you have sort of ballpark figures for us?
I can help. It's a bit theoretical, isn't it? Because the WHO recommendations is 0.8 grams per kilo of body weight per day. I propose, and I have done a review of this in the early 2000s, where demonstrating that there is a benefit if it is 1.2 grams per day. Now, this is all very theoretical. The idea here is that we should have protein in every meal. We tend to eat more protein by the end of the day. In general, what our studies and those by other groups is that we should have a minimum of 20 grams of proteins per meal per day. And despite the fact that older people, they might have lost weight, or one more reason to give more protein. So what is 20 grams of protein per meal? You can have 20 grams of protein if you take, let's say, a steak of 100 grams, 3 ounces. Okay, not a 16-ounce steak, just 3 ounces gives you the 20 grams. It's also 2 Portuguese sardines. I have to say Portuguese because they are particularly good sardines. But it's also 2 eggs. Is also 2 yogurt. It's also a glass of milk of 16 ounces of milk, which we have difficulty with lactose intolerance in certain people. But just to give you this a variety, it's also, if you take lentils, if you take all kinds of cereals, that we can obtain that amount. But we consider that the needs of protein increases because studies have shown what we call anabolic resistance. In order to derive the same amount of muscle protein synthesis with age, you need more protein. This is why we call resistance, because this resistance can be overcome by putting more protein in diet. Yes.
Next question is, how do you quantitate hand grip strength? And I guess to follow up on that, is that a good marker of frailty in this population?
Yes, it's an excellent marker for many conditions. So hand grip is done with the dynamometer. There is several in the market. This has been well studied. You know, hand grip, the person who squeezes the handle, for women, they should squeeze it with more than 16 kilos of force, and in men, 26. Any value below that has been associated with bad outcomes. For different reasons. Sometimes it's because of sarcopenia, which is the atrophy of muscle mass with age, but it's also because of malnutrition. People who are malnourished, they develop less strength. And hand grip have been associated with so many things, such as prolonged length of stay in hospital, risk of falls, the fact that they are malnourished. So it's a good index of general good health as well.
Fantastic. You know, as cardiologists, Jose, we get referred a lot of elderly patients that have fallen, and there's always this question of, you know, syncope or no syncope. And it's very hard because the histories, you know, not everyone can give, I guess, a good history, and that applies, you know, across the board at all ages. Do you have any data on that? Like, you know, in terms of these sort of elderly patients that fall, that how much sort of syncope is missed? How important is it to do, you know, the Holter testing and all this cardiac evaluation? Will you be able to help guide us with this?
Yeah, we should not be sending patients for Holter because they have fallen, but you should be sending those who are highly suspicious for something cardiac origin. And you can get that information by doing a careful history, and sometimes verifying with family member, because the older person might not have all the cognitive capacity to give these details. Unfortunately, you know, I think there's sometimes too many Holters being ordered, and the reverse is true as well. For those who should have had, sometimes they are not requested. So it takes time and accuracy in your assessment. But let me tell you, start by a EKG and verify if there is a sinus rhythm there, if there is no PR interval that is getting longer and longer and skip beats and all kinds of things, and malaise before, and the warning signs. When it's cardiac, there is something announcing most of the time that something is wrong, the way they feel, etc. As opposed to the so-called mechanical fall when when there is a rug on the way that we trip on it. Even though I insist to say that if they trip on it, a younger person might not have tripped on it. So there's causes explaining the reason for. But to get back to the alter, I don't have data precisely because in serious cardiovascular as well as neurological epilepsy, for example, there is a true syncope as opposed to just undefined symptoms. That's much I can go. I'm not an expert on syncope per se. Yeah.
Fantastic. Just one last question for you, because we're getting close to the top of the hour. How do we send our patients who are, to you and to get them onto with your team? Can you just give us maybe some
we have our outside ambulatory clinics that we can refer patients to. In fact, in 2014, I created a specific falls clinic that is now run by Dr. Gustavo Duque, a world expert on falls and frailty. So just send a request to geriatric clinic. And I can give the number to those. It's our general hospital hospital number with the fax. So 934-8286 in the 514, right? 934-8286. Send a fax request. Don't send it to me. My email inbox is too many.
Fantastic. Nice positive comments in the comment section here. I'd like to thank you very much, José, for this really terrific, very comprehensive lecture. As someone pointed here, we learned a lot. Many thanks. We all learned a lot today. David Morris, I agree with you. Really very, very exciting. And thank you. And continue to do this great work. We really need you out there. So thanks everyone for joining us. And I wish everyone a terrific afternoon. Thank you.
Bye. Thank you.